You guys see that? All right. Now, do you guys know about IV therapy and ports? IV therapy and ports.
Yes.
Where do you put the most lethal IV medication? Well, I mean, you could put it in a central line, but so I have 2 or 3 ports in this line. Say I got IV right here, have 2 or 3 ports. The closest port. The closest port, dude, to the heart, to the vein. Why is that? Because if you turn it off, we don't have a whole line to infuse. Do you guys see that?
Say that again?
Look, I got, look, just listen, just watch me. Okay, I got an IV line right here, okay? I've got a port right here and a port right here. Am I gonna put my magnesium sulfate port right here? And my LR port down here? Or let's say, I don't know, DW, you know, because this is an LR running, whatever. Am I gonna put it closest to my vein, the magnesium sulfate, or furthest from my vein? Why closest to my vein? Because if I turn it off, I'm not going to have this whole line run in. How much am I going to run in? From the lowest port to my vasculature. Do you guys see that? So it's less damaging. So when you're running mag sulfate or lethal drugs, dudes, where do they need to be? In the lowest port. Because it's a shorter line. So if it was up here, you guys, and I turned it off, and then I flushed this line out with my LR, because it's going to keep running, I'm going to run from here all the way down, all the medication that was in that line. Dude, okay, let me draw a picture.
Are you talking about tubing?
Yeah, tubing. It's not
I thought your arm like that. I have multiple ideas.
Yeah.
I understand now.
Okay. So here's the line. Here's a port. Okay. And here's a port. And now I've got another line running into this port. And another line running into this port. You guys see this? See that? So if I have mag in here, and this is my LR running through here, right? It's picking up my mag and taking it. And if I need to turn this off because of an emergency situation, I've got this much in my line that's going to go into my patient. Whereas if I hang it at this port, mag, you see, all I have is this. See that, you guys? So everything that's in that line is going to run. So whenever you have lethal drugs that can cause lethality, like mag sulfate, you're always going to put them in the lowest port.
Do you burn the vein down there?
You know, I mean, you're not going to use PICC line because it's more invasive than what we need. Yeah. Okay, so you guys, so we talked about magnesium sulfate. You need to do some assessments when they're on magnesium sulfate. Number 1, you need to continually do A's and O's, A and O times 4, 1 to 4 hours. It depends on your source, how often we should do it when they're having magnesium sulfate running. Could they go into a coma if they got too much? Yes. You're going to do blood pressure, right? Blood pressure every 1 to 4 hours, because could you decrease their blood pressure too much? Yes. You put them hypotensive. If mom gets hypotensive, who gets hypotensive? Placenta and the baby, the heart tones go down, emergency C-section. Okay? You need to do DTRs, deep tendon reflexes. That's the other side of A's and O's, right? A and O times 4, well, that's verbal, but I can have an objective sign, right? By doing my DTRs. If my DTRs are +1 to +2, I'm good, right? If I have absent DTRs, what does that mean? Too much suppression of my CNS, okay? We also are going to check output. For who's the key player there, dudes? Kidneys. So we're going to check output and make sure that we have at least how many? 30. Yeah? Okay, so you guys, that is your assessments. If it ever gets, if you get respiratory problems or any of these things start, we may have to give the calcium gluconate. Okay, you may have to give it. Go ahead, Amanda.
Is the, how frequent, like the 1 to 4 hours, depend on how much you're getting, or?
Pretty much,
Okay.
and depends on how conservative. Like, I have to tell you, like, I wrote policy at Baptist Beaches, and I was like, every hour. Because A1 says at least every 4 hours, but dudes, if you can catch a problem, and because dude, it's, the A1 says it should be a 1-to-1 ratio when you have somebody on MAG. 1 nurse, 1 patient. So you should be evaluating those things, because it's like a high-risk ICU patient, because of that medication can be lethal. Go ahead, Sophia. Oh, yeah, go ahead.
So what other drugs, like what kind of, can you just paint the picture, what kind of drugs that they are on? You said that they'll be like on the beta blockers still with the
They'll be on
MAG?
Yeah, so,
And then probably
Well-
like a head burner.
okay, so listen, you guys, so all that mag sulfate's gonna do is be a neuroprotector for the baby and prevent mom from having seizures. Blood pressure is a separate issue, right? So blood pressure, they're gonna be on a beta blocker, okay? And it's in here, it's in the notes, but dude, this is weird, I can't see my thing. I hate it when I can't see my thing.
Are they gonna have this patient on the general research floor?
Where
Oh,
does it
no,
go?
this patient will be in labor and delivery, for sure. Okay, now listen, you guys, so I can't get this up, so we're just gonna keep talking. Okay, so the goal, the goal is a healthy mom and baby, okay, the end. So, dudes, guess what? If we're worried that mom's blood pressure is getting so high and this baby is 23 weeks old, we're gonna do a C-section if we think the mom's gonna stroke because of this hypertension. Now, as Colin was saying, what about brain, Julie? So I had a student in this class, and I'm talking about, okay, so this can get so much ICP that you can herniate your brainstem. She raises her hand, and she goes, my aunt is in a nursing home because she herniated her brainstem. And she's a vegetable living in a nursing home because of pregnancy-induced hypertension preeclampsia.
Oh my God.
Dude, listen, like, I thought I was gonna, oh, hey, what's up? Well, it is very sexual. It will be, I think that's.
Oh, this is.
Yeah.
Sorry.
Great answer.
She was so sweet. Alright, so you guys,
Just gonna keep walking.
so, anyway, it can cause so much pressure on the brain, you can herniate. I mean, people die, but so you can die of a brain herniation because, your brainstem regulates your respiration. So you guys, you can knock it out, okay? So that's one thing with preeclampsia. And you guys, we used to have a lot of maternal deaths before we had mag sulfate. People in foreign countries, things like that, who don't have access to care, have barriers in care, it can be really bad. Now, one thing I will say about what people in the United States, what happens to them residually with pregnancy-induced hypertension. Okay, so if the pressure gets really high and the heart is working really hard, so you guys, when you get preeclampsia, you retain fluid, okay? You retain fluid. So your vasculature is taxed out, you get a lot of pressure on your heart. They can have cardiomyopathy, postpartum cardiomyopathy, from all that pressure and all that hypertension on their heart. So that's why I'm saying, we'll take the baby if it's gonna kill you. We're gonna, no matter what the fetal age of the baby is, if it's gonna kill the mom. Now, so we've got cardiomyopathy can be a residual from this, and brainstem herniation can be a residual from this. So those are two big maternal hazards. Also, vascular damage. So diabetes and pregnancy-induced hypertension are besties. And so when you have diabetes, okay, so one more time with physiology and pathophysiology. If you regulate your blood sugar, okay, God, I thought that was another sexual person. If you regulate your blood sugar, if you regulate your blood sugar, what are your maternal outcomes versus someone who does not have diabetes? Same. But if you don't regulate your blood sugar, it causes inflammation of these vessels, right? And then what do these vessels do? Calcify. Okay, so we have inflammation of these vessels, they calcify. Guess what we start doing, bros? Putting out that dang acid. So now, you've got gestational diabetes, because you had unregulated, you got vascular damage. It starts putting out the acid, and guess what it's going to throw on now? Hypertension. Okay? What?
So it's just like, I mean, most diabetics are hypertensive too. So
I
it's like
know,
just
just
like
think about that, yeah. So now you've got, but that's the thromboxane thing, activated in the vasculature. So you guys, now these two, now you've got these two on board. Okay, so we've got a big baby, we've got a hypertensive, this is a mess, okay? This is super scary because we're trying to regulate her blood pressure. She's hypertensive. We don't know if we have enough lung surfactant. We're trying, you see what I'm saying with the baby? So we've got all these multiple variables going on here. So these two are besties, they hold hands, and a lot of times you're gonna have a gestational diabetic and a hypertensive patient. And we're gonna have multiple ultrasounds. Just the cost of taking care of this patient is so enormous. They go for weekly biophysical profiles with a perinatologist. Okay, that runs about $1,200 to $1,400 a pop to make sure that this placenta's fine and their babies are okay. Yeah? So just think about our increasing waistlines and how much healthcare costs dollars. I'm just saying, just look at the global picture, not global, US picture, and see with that. So you guys, when you have vascular, so when we have hypertension, so say for instance, I just want you to think about, if this goes on and we don't, so what is the cure for gestational hypertension or preeclampsia? Delivery. Delivery is secure. So I just want to think about, I want you to think about pressure on your veins. So if we don't deliver and we keep you pregnant and you have gestational hypertension, of course our baby is going to have problems because of the pressure. It's going to be tiny, small, not get enough oxygen. But a fireman, okay, so I'm going to talk about, I am a person with normal blood pressure, okay, a normal blood pressure person. It's like me having a water hose. This is the vasculature of the wall of your vessel. It's like me having a water hose. Is it going to damage this? No, because the pressure's not high. The water's going to hit it and it's going to come off, right? So when you're normotensive, do you have any inflammation or any damage to your vasculature? No. If you have pregnancy-induced hypertension, what happens here? It's like a fire hose and you are banging this vasculature and you're causing big chunks of it. You can damage your vasculature, and guess what else? Your red blood cell hits this really hard and fast, and what does it do? Lyses. So what do they get? They get decreased RBCs because of this high blood pressure. Now, when this high blood pressure keeps doing this, and it keeps tearing at your wall, right? What does your body do to say, hey, this wall is damaged, we don't want a blood clot here? What does it do?
Platelets.
Platelets. What do the platelets do? They smooth it all out, right? She said 10:40. What time is it? 10:40. So they line it, right? So what happens to your circulating platelets? They go down, and you're at risk for what? A hemorrhage. You can bleed out. Now, add one more thing. So dudes, the platelets. So now, the platelets aren't effective. We've got so much, we've thrown out all of our platelets. What else are you going to throw out? Fibrin and fibrinogen. What is that going to do? That's going to initially cause you to hypercoagulate, to put all of your clotting factors on these walls so you don't throw a clot, right? So you're going to initially hypercoagulate, and you could have a what? DVT, PE, and then once that's gone, this is called DIC, disseminated intravascular coagulation. What else is going to happen then? No clotting factors, and you're going to
bleed it.
Yeah.
Okay, thanks, Steve.
Aren't we having a quiz today?
Yep. We're supposed to. But, not.
Study. Man, I wish she would have taught half of this.
Taught every class.
The hybrid class.